Analgesia in labor. The pain threshold may be low during labor on account of fear, anxiety, and uncertainty. The adequate pain relief during labor results in less anxiety and good progress. So, in the first stage of labor, pain relief may be required for painful uterine contractions, whereas in the second stage of labor, analgesia is required for instrumental delivery and when an episiotomy is given. So, pharmacological treatment during the first stage of labor, as parenteral, give morphine IV 2.5 to 5 milligrams 4 hourly as required, and metoclopramide IV 5 to 10 milligrams 8 hourly as required for vomiting, or pethidine hydrochloride IM 50 to 100 milligrams that and repeated as required 3 to 4 hours later, the maximum of 400 milligrams in 24 hours, or promethazine IV or IM 25 milligrams as required, the maximum of 25 milligrams 6 hourly as required to reduce the chances of vomiting and also to potentiate the analgesic effect of pethidine. Given IM, the maximum analgesic effect of pethidine is obtained after 45 minutes and lasts for 3 to 4 hours. It is therefore best not to give it when delivery is anticipated within 4 hours. That is up to 6 to 7 centimeters dilatation. If the baby is born within 6 hours of pethidine administration, it may have respiratory depression requiring narcotic antagonists such as naloxone IM 100 micrograms per kilogram stat. If no response, you give subsequent dose of 100 micrograms after 3 to 8 minutes and continue resuscitation with oxygen via face mask or through an endotracheal tube and self-inflating abu bag until the depression is reversed. However, pethidine should not be withheld from patients who need analgesia. That's when the cervix is already 6 to 7 centimeters dilated, in which case 50 to 75 milligrams IM pethidine with 12.5 to 25 milligrams promethazine may be given intravenously. During the first stage of labor, as inhalational stage, you give nitrous oxide and oxygen mixture, that's 50-50, and to be used in the late first stage. That's when delivery is expected within 1 hour. During the first stage of labor, epidural, this procedure is best carried out by an anesthetist. So during the second stage of labor, local anesthetics for episiotomy and pudendal block anesthesia to facilitate instrumental delivery is done. Lidocaine hydrochloride as a combination of xylocaine, lignocaine or lignocaine 1% with or without adrenaline infiltrated in the perineum before an episiotomy is done. If this is not given before delivery, it can be given before the repair of the episiotomy. Anesthesia for short obstetric procedures, for example, manual removal of placenta, repair of large vaginal and cervical tears. Give pethidine IM or IV 1 milligram per kilogram slowly with a maximum of 100 milligrams if no anesthetist is available. And promethazine hydrochloride IM 25 milligrams stat if vomiting occurs, or metoclopramide IV 5 to 10 milligrams 8 hourly as required, and diazepam slow IV 5 to 10 milligrams at a rate of 2.5 milligrams per minute. So you monitor respiratory rate closely and you stop diazepam if respiratory rate is less than 10 breaths per minute, and do not mix the two drugs in the same syringe. The second line treatment, you give ketamine IM 5 to 10 milligrams per kilogram start, or ketamine IV slowly 1 to 2 milligrams per kilogram, or ketamine IV infusion for longer procedures 1 milligram per milliliters of ketamine in dextrose 5% or normal saline, and maintenance dose 10 to 45 micrograms per kilogram per minute, adjusted according to response. And also diazepam slow IV 5 to 10 milligrams administered over 2 to 3 minutes, approximately 2.5 milligrams per minute, to prevent hallucinations. Pre-medication before ketamine administration: give atropine IM 600 micrograms start, and oxygen by face mask 6 to 8 liters per minute. The ketamine is contraindicated in patients with high blood pressure, as hypertension and heart disease.